Welcome back, everyone. Before mastectomies became part of the national conversation, thanks to high-profile patients like Angelina Jolie, an Augusta woman had surgery to remove both breasts in order to fight breast cancer. Doctors found a mass only in one breast, but because of her family history, she felt removing both was the way to go, and a local plastic surgeon eased her anxiety about the disfiguring surgery and her options afterward.
My mother died of breast cancer at the age of 73. It was triple negative. It was a very rare, very aggressive cancer. 2 weeks after she passed away, they found a mass in my breast and had a mammogram, had a sonogram. The consensus was that I needed to have a bilateral mastectomy.
And so if these women already have a breast cancer, it may not make sense to leave large amounts of tissue behind to form another one. And many of these women are also interested in risk reduction surgery.
Dr. Edmund Ritter is with me right now. It's so interesting what you're showing me here. You can see that we have a lot of different implants and a pocket that you're going to explain to us. What's inside the silicone breasts has changed over the years?
It's improved.
Improved, yeah.
Improved. We have better implants, we have better shells, which are made out of silicone, and we have better fill for them.
And the shape is also something that's very interesting, from just the rounded shape to the one here that's more of a teardrop.
Exactly. The teardrop people refer to as anatomic, and particularly in reconstructive use, the anatomic has a lot of advantages. If a patient has a normal amount of breast tissue and we're enhancing, if we're augmenting, and we could slip an implant behind the breast itself, it's less noticeable which type of an implant you use. In fact, there have been MRI studies where they show that the implant really changes its shape a lot when it's put behind a normal breast. We've had a progression in tissue expander based alloplastic breast reconstruction, where we're no longer putting it behind the pectoralis muscle for most patients. So when we're doing breast reconstructions, we're often putting the implant right behind the skin and sometimes a layer of biologic tissue and fat grafting over it. And in that case, you can see that this would provide a much more normal looking breast than the round for many patients and give better upper pole fullness. The whole issue with upper pole fullness is also important in augmentation, particularly in women who are very slender, who like to have some fullness here. Think back to reruns of Baywatch.
Right.
The Baywatch look.
Now, this was very interesting because this is, as you were explaining, the pocket.
Exactly.
That you use in reconstruction.
In the trade, people will refer to this as a tissue expander. So one example where tissue expansion would be worthwhile is a patient who's having a delayed reconstruction. In other words, if a patient has breast cancer, they can have an immediate reconstruction at the time of the mastectomy, or at some later date they can have a delayed reconstruction. And the role for the tissue expander in the delayed reconstruction is to place it underneath the skin, or sometimes skin and muscle, and then we fill it. And that can be filled with air, but we usually use sterile salt water. And so you can imagine, do we need to hold that up? Is this is inflated underneath the skin, it makes a pocket that's breast-shaped.
And then into that pocket, you're going to slide the implant.
Exactly. We can either put the implant, or some patients want to have their own tissue used. We can take skin and fat from the lower abdomen and put it in the pocket. But by having stretched the skin, we have tissue that all matches the same color in the chest. So not only are we stretching skin, but when we do tissue expansion, we actually generate tissue. It causes cells to proliferate and grow.
Okay.
So you can see, you can imagine if this was in a patient who was having a breast reconstruction, you can see how slowly filling it leads to producing a soft tissue envelope that looks like a breast.
Okay.
My religious patients will say only God can make a breast. We do our best. And when you think of breast surgery, you think of enveloping contents. The envelope being the skin and soft tissue. The contents can be tissue or an implant. So this is designed to give us an envelope to put our breast tissue into. You can see that's starting to look like
It certainly is,
breast.
like the breast implant over there. Okay. So that's how you're getting the body ready to accept that implant.
In making adequate soft tissue coverage. So one of the key things for a successful breast reconstruction or breast augmentation is to have adequate soft tissue to cover it. In patients that have had radiation and don't have adequate soft tissue, we have to bring tissue in, and that's another topic. But you can see once this has been expanded under the skin, now we have a pocket.
Okay.
We can put an implant in, or we could take a patient's own tissue from either the middle of their thighs or from their lower abdomen are our two top choices.
Okay. Fascinating. Now before we wrap this up, you've brought a scalpel and you're going to show us why these are called gummy bears. We're going to cut one open, right?
Absolutely.
Just wait for this.
Us plastic surgeons all have a little element of showman in us, don't we? One of the advantages of the cohesive gel is that if the shell were to fail, the gel is supposed to stay together. People have been concerned with the old-fashioned implants that if the shell fails, the silicone moves around in the body.
Would leak, right?
So we have a couple implants here. This is an old-fashioned implant. This is a gel implant, and if I cut it, you see that it tends to come out.
Okay.
Versus with the cohesive gel, you see that's not going anywhere, is it?
No, it's like cutting into Jell-O.
Exactly. So even if the shell were to age and fail,
yeah, no, it's just staying right there.
it stays there.
Yeah. Okay. And that sticky is the cohesiveness, I guess.
Yes.
Yeah. All right.
It takes chemists smarter than all of us to figure that out, but that's what happens.
Well, Dr. Ritter, thank you very much for coming and talking about all this with us today. And Dr. Ritter is at the Medical College of Georgia at Augusta University, and you can find him by looking up plastic surgeons and getting a hold of your group over there.
Sure.
And again, reconstructive and cosmetic surgery.
It's our pleasure. One of our jobs as surgeons is to educate people so they can make decisions in terms of what's best for them. That's truly what informed consent is. We're not just educating trainees, medical students, but when patients have enough information, they can figure out what's best for them, whether it's an implant or fat grafting or a flap or whatever it might be.
Good information. And we'll be right back.